as Dr. Tanu Singhal said, since we have taken some vaccines in our purview, we continue with vaccination. We had a lot of syllabus planned, but first we'll finish the vaccines because that is so relevant to all of us. So the next vaccine that we want to discuss is the herpes vaccine. Herpes vaccine is not available yet in India. The brand name is Shingrix, S-H-I-N-G as in shingles, R-I-X as in risk. Shingrix is a vaccine available in the US, 2-dose vaccine, I think. What is the schedule? I don't know.
Yeah. So it's a 2-dose vaccine with 2 doses given at interval of, I think, 8 to 24 weeks, like 2 months to 6 months interval.
Correct. So this is, of course, not available here, but it might come soon.
It might. I have heard that it will probably come by the end of this year, because this is an important vaccine for elderly, because you've all seen the problem with herpes zoster. You know, it can cause terrible pain, post-herpetic neuralgia. So basically the indications would be anybody above the age of 50 or those who have an underlying immunocompromised state. They would be the candidates. Earlier we had another vaccine called Zostavax. So Zostavax was a vaccine which was like the chickenpox vaccine. It had the live virus, live varicella zoster virus. So therefore that vaccine was not indicated for immunocompromised people who actually need the vaccine, because you know, if you are on steroids or you are HIV, you get herpes zoster. So this is an advantage of this because it's a killed vaccine. So that is why it is a superior vaccine to Zostavax, and when it comes, we should include it in our list of vaccines which we recommend to the elderly and immunocompromised people.
It is expected that the vaccine will be costly. It will definitely be more than 5,000 rupees per dose retail dealer price. So I think that might be a little this. But as she said, mandatory above 50, meaning you must convince every patient to take it because you've seen the morbidity of herpes. One thing here very important is if a person of say 55 has had herpes at the age of 55, you still recommend the vaccine and still recommend 2 doses of the vaccine because herpes is a problem that can reoccur. Right?
Yes, though the benefit will be the greatest for those people who have not had an episode.
Okay.
Any relation to somebody who has had chickenpox, whether that would make any difference in giving the herpes zoster vaccine?
Actually, if you've had chickenpox earlier, you are at greater risk. But you know, the thing is that many people would have been infected with chickenpox and they would not know about it because many infections with chickenpox are actually subclinical. So you cannot say that, somebody will say that I've never had chickenpox, so why should I take the herpes zoster vaccine, because it's your latent virus which causes herpes zoster. So you could have been subclinically infected. So there is no need to do a varicella IgG test or something before giving the vaccine.
And if they've taken the chickenpox vaccine, I know my pediatric population still won't become 55 till then, but many mothers and adults have taken chickenpox vaccine. Would they also require to take the zoster vaccine?
Yes. Because one thing is that you can still get mild chickenpox even after taking the vaccine. If you've taken 1 dose, you could have been infected with chickenpox before you took the vaccine if you took it at a later age. So that is not an exclusion criteria. And we know that chickenpox vaccine does not absolutely protect from herpes zoster. So why does herpes zoster occur? Because your immunity drops down and this virus is latent in your body. So whenever your immunity drops, you get herpes zoster. So by giving this vaccine, you are boosting your antibodies against chickenpox.
Correct. Yeah, any question on herpes vaccine only? Yeah. Hiren. He's asking, can we give chickenpox vaccine as a herpes vaccine?
No, you can't, because the dose, the amount of dose of the virus which you need is much higher than what is there in chickenpox. So you cannot give chickenpox vaccine to protect against herpes zoster.
He's asking, he has taken Zostavax in the past.
Yes, you would need it because the Zostavax vaccine also gave protection only for 3 to 5 years. So, and that was not such a good vaccine. So I think if you are a candidate and if this Shingrix is available, you would take it.
Is the vaccine lifelong if 2 doses are given?
So for now, the recommendations are only 2 doses.
For life. Sorry, is?
Herpes zoster, no, it's not a life-threatening disease, but it can be side-threatening. Many people can get it in the ophthalmic branch of the trigeminal. It can also cause meningitis, encephalitis, and I think the problem is the post-herpetic neuralgia, which can be very painful.
If it, I mean, he's asking whether herpes is life-threatening. I'll tell you just one incident. I had one patient with post-herpetic neuralgia who did not respond to anything. She committed suicide because of the pain, intolerable pain. So you must realize that the pain is intolerable in many patients and prolonged, can last years. So there's no excuse.
I mean, as a general concept, you should offer the vaccines to people, explain to them the benefits, but then finally the choice rests with them because you cannot forcefully vaccinate. You can tell them about this, and it is, you will explain about the vaccine to, let's say, X amount of people, but only there will be a fraction of the X who will actually end up taking the vaccine. But if we have explained about the vaccine, then our work is done.
Okay, so that's about herpes vaccine. We take the next.
Chickenpox vaccine?
Chickenpox vaccine,
yeah. So can you tell us for pediatrics, what is the need for taking chickenpox? As somebody asked, not life-threatening, so many say, okay, why take chickenpox vaccine? One, it does not give you guarantee to no chickenpox, and anyway, chickenpox is relatively mild in non-immunocompromised children.
Yeah, so that is why the chickenpox vaccine is not part of our national program, because only those vaccines are included which give, significant mortality benefit. But in the otherwise population who can afford to take the vaccine, chickenpox can be a problem because one, so there is one thing about chickenpox epidemiology which you must understand, which is relevant to India. What happens in the West, that if you have not taken the vaccine, most people acquire natural infection and become immune. But in India, which is a tropical country, the virus, if it is there in the environment, it dies very quickly because of the high temperature. So there will be 15 to 20% of people who will grow up to be adults without being immune to chickenpox. And in fact, in a study done in our hospital where we have nurses from Kerala, 35% were seronegative for chickenpox when they joined. That is why all the time you will see young women getting chickenpox, because 15% of our population is seronegative. So if you give chickenpox vaccine to a person who's a child, then you are ensuring that they will not get chickenpox when they grow up, which can be a debilitating disease at that time. Also, if the child is in 10th standard, appearing for board exams and gets chickenpox, it can mess with their career. So compared to the cost and the safety of the vaccine, I think it's a good vaccine to give. And if you give 2 doses of the vaccine 3 months apart, you get almost 100% protection against natural chickenpox. If you give 1 dose, then you get 100% protection against severe disease. You can still get mild chickenpox. And there are some people who say that let's not give the vaccine now. Once the patient is 10 years old, agar usko chickenpox nahi hua, then we'll give the vaccine. That is another concept which was there in the past, because let them get natural chickenpox before age 10, because then, they will get more durable immunity against chickenpox as compared to the vaccine. But remember that the immunogenicity of the chickenpox vaccine decreases as you advance age. So if your 2 doses were giving you 100% protection in infancy, it will give you 80 to 90% protection when you grow up. So the best time to immunize against chickenpox is in the 2nd year of life.
In adults who have not taken chickenpox vaccine, what do you do?
So there are patients who come to you for vaccination, this thing. So you would do their chickenpox antibodies, because many people who don't, even if they say that we had chickenpox, many times you don't know whether it was really chickenpox or it was some disease. So the history of chickenpox is not a reliable indicator of immunity. So you would do their antibody levels. If their antibodies are positive, it means that they don't need the vaccine. If their antibodies are negative and they are not pregnant and they are not immunocompromised, then you should give them 2 doses of the vaccine 4 to 8 weeks apart.
Can I ask this? This is slightly twisted, because the cost of Shingrix will be high. Can I, in a young 35-year-old, say, do the antibodies? Antibodies are absent. Never had chickenpox, therefore. I give them 2 doses of chickenpox now to be able to protect them even from herpes later, because chickenpox nahi hua to herpes nahi hoga.
Yes.
Is that a logical thing?
That's a logical thing because your chickenpox vaccine also protects you from herpes zoster later. It reduces the risk because it reduces the risk of natural chickenpox, and there is no data that you can have vaccine derived zoster later because the vaccine virus is also lying in your body now. So it gives dual benefits. It protects you from chickenpox at this age, which can be serious. What if this woman gets pregnant and then she gets chickenpox? Then her child, the baby, is at risk of congenital varicella syndrome, and there are women who have terminated their pregnancies because they've got chickenpox in pregnancy. So, and later on they protect from getting herpes zoster.
Chickenpox antibodies, I have never asked any patient to do. Easily available?
Very easily
Very
available.
Not very expensive?
Not expensive.
It's around 1,500 rupees. So somebody was asking that what's the point of doing antibodies? And I think it's better to do because one, it's a live virus vaccine. And so the cost of the vaccine is 2,000. So if you're giving 2 doses, it will be costing 4,000. So if you're, and 80 to 85% of the population is antibody positive. So that's why the economics is cheaper if you do the antibody. Of course, the patient where the antibodies turn out negative, they will have to shell out more money because then you're doing the antibody test and the vaccine. But the guideline is very clear that you check the antibodies. If they're negative, then you give the vaccine. And you have to tell the patient that once the vaccine has been given, they should defer pregnancy for at least 1 month.
But if they have taken the vaccine and then they come to know that they have become pregnant, what do you advise?
Nothing, because you won't terminate the pregnancy. So either MMR or chickenpox, though they are live vaccines and not recommended in pregnancy, but if they have inadvertently become pregnant or they were pregnant at the time of vaccination, you do nothing.
Yeah, so we'll go to the next vaccine. People have stopped asking questions because there are somnolence. There's no other reason.
No, there's just one more thing about chickenpox vaccine being used as post-exposure prophylaxis. That is also something, because sometimes what happens is in a family, there's one child who gets chickenpox. Now everybody gets worried because chickenpox is a highly transmissible disease. So then you can also offer post-exposure prophylaxis. So you do antibody levels in the family members, and whoever is antibody negative, you can give them the vaccine within 3 days of exposure and they will be protected from chickenpox.
Is the vaccine given without doing the antibodies?
No, it's just the cost of the vaccine. But you have to ensure that you can only give it to immunocompetent people and non-pregnant people.
So live vaccine, remember that, yeah.
Yes, 2 doses.
Okay, any question on chickenpox? Yes. I'll repeat the question. If 1 dose has been taken and the patient comes out of many years, can you count that dose as taken?
Absolutely, it's a principle for all vaccines. You count it as taken.
Supplementary question would be, if their IgG is positive now, whether would we advise them the second dose, or would we say one is there and you're...
No, you would advise them the second dose, because what happens is that the IgG is not an accurate marker of how much immunity you have got in your body. You may not have good cell-mediated immunity. Otherwise, that concept would apply to every vaccine. If you take 1 dose of hepatitis B and you do your antibodies after 1 month, it will be positive. But that doesn't mean that you will not take the second and the third dose of hepatitis B.
So if the IgG is positive, you may not start giving vaccination, but if it's an incomplete course, then don't do the antibody. Go ahead and make sure you finish the second dose without doing the antibody. That's the message.
No. Only chickenpox is 2-dose vaccine, so no third dose. No booster. Yeah, so remember, chickenpox has an incubation period of 14 to 21 days. So it has a long incubation period. And I said you should do it within 3 days. That's why that concept. Now, if their chickenpox becomes infectious 1 day before the rash starts. So suppose they have come after 5 days. 5 days ke baad they have come, then giving post-exposure prophylaxis is not beneficial. So that is why it should be done within the first 3 days.
What I tell them at least is, even if you explain to them that this may not be beneficial, But if you are not, if your if your antibodies are not there, it's anyway good to take it, and so you go ahead and take it. To answer your question, even if they are in that incubation period, you are not doing any harm in giving it, even if they get it after taking the vaccine. Suppose after 1 week they get the infection, all you have to mention is that you may get it and you are not protected with this vaccine for this exposure.
And also then you would not give them the second dose later if they've already got natural chickenpox. In fact, there are some studies to say you can give it even up to 5 days. So 3 to 5 days, till then you can give it. And what he said is correct, that at least you use this opportunity to check their antibody levels and anyway give them the vaccine. But in that case, you know, if they are, remember that if their antibodies are negative and they have been closely associated with chickenpox, and 5-7 days are passed now, then there is a high probability that they'll get natural chickenpox. Then the vaccine would be a waste. So then in that case, you can wait till the incubation period is over and vaccinate. What you must tell these people that even though you're not a candidate for the vaccine, the moment you get the first lesion of chickenpox, come and we'll start valacyclovir for you. Because the earlier you start the valacyclovir, the lower is the risk of severe disease. So that counseling you must give, because many of these patients come after 2-3 days when they are not candidates for valacyclovir.
Which children would you recommend to be given antivirals for chickenpox infection?
So studies show that if you start within 24 hours of the rash, you get a 25% lower number of lesions. So it depends. So if the child has had taken 1 dose of the vaccine and now has got breakthrough chickenpox, we expect it to be a mild illness. So you would not give antivirals. But if you have a child who's like 9 or 10 years old who has not taken the vaccine and who has got chickenpox, then that patient can have severe disease. There can be hundreds of lesions on the body which might leave scars and other things. Then you must give them antivirals.
Yeah. The next vaccine that I want to discuss is hepatitis B vaccine. Adults.
Yes, it's available. Syrup Zovirax is available. Dosage is 20 mg per kg 4 times a day for 5 days.
This is a dosage of acyclovir. Yeah, so hepatitis B vaccine, how many of you have taken a vaccine in the last 7 years? Last 7 years? No. Hepatitis B. Okay. Okay. Tell us about healthcare workers and hepatitis B vaccination.
See, you all should take hepatitis B vaccine, and 1 month after doing your vaccination, you must check your anti-HBs levels. If your anti-HBs levels are more than 10, it means you are protected for life. You don't need to take boosters. And unless you become immunocompromised for any reason, then it's a different matter. So that, and then there are many people who say that I took the vaccine 5 years back, I took the vaccine 10 years back. So to them we recommend that you take 1 dose right now, and 1 month after that dose check your anti-HBs. If your anti-HBs is more than 10, it means you are a responder and you don't need to take boosters of Hep B later. So doing an anti-HBs after you have completed your vaccination schedule is very important, because we know that there are 10% of people who are genetic non-responders to hepatitis B, that despite taking the vaccine, they will not have anti-HBs levels. And these are the people who need to take a second course of the vaccine, either a higher dose of the vaccine or intradermal vaccine. And then there are some who may not respond to this second schedule and they remain permanently susceptible. So I don't know how many of you know your anti-HBs levels.
Anti-HBs is a blood test, anti-hepatitis B surface antigen antibody. Now this tells us about the immune status. More than 10, we are immune. Less than 10, we are not immune. So she's asking, would you do your anti-HBs if you have not done, and if you have taken your vaccine schedule decades ago, would you do your anti-HBs? You should do, right?
But you should take 1 dose and do it, because what happens is, over time, your anti-HBs levels decline. Okay, so if you have taken your HBs vaccine 10 years ago and you do your anti-HBs level now, it may come less than 10. It doesn't mean you are a non-responder. It means that you may have responded, but your antibodies have naturally declined. So you should take a vaccine dose and then do it 1 month after the vaccine. Because remember that even if your levels after 5 years become negative, your memory cells are there, which will react when you are exposed and will produce the antibodies. So the anti-HBs is just a surrogate marker of saying that your body has responded to the vaccine and you have memory cells with you.
Ma'am, just a second.
So
If
I'm
you have
sorry.
got infection with hepatitis B, taken a hepatitis B vaccine, then got an infection for some reason, what about the next dose of vaccine?
No, so once you are Hep B infected, you can't take the vaccine because you are hepatitis B. Either you will be HBsAg positive
Carrier
or
or
carriers, or if you lose it, you will automatically, naturally become immune to hepatitis B. And what is very important is that if there is one person in the family who's infected with Hep B, it is a disease which is very easily transmitted by close contact, and like HIV. So it is mandatory to test all the people in the family first for antigen, and if they are antigen negative, then give them the vaccine.
So in summary, for all of us, tomorrow you take the booster or whatever dose you call it of hepatitis B vaccine. After 1 month, check the anti-HBs. If it is still less than 10, what do you do?
So in that case, we would recommend that you complete the course, because we don't know about your past things. So then what you would do is you would take another dose after 1 month, and you would take another dose after 6 months, and then you check your levels after 6 months and see. If your level is negative still, then it means you are a non-responder. Then you can either go for higher dose hepatitis B or intradermal hepatitis B, and then see if you respond. Because we must remember that as you age, your ability to respond to hepatitis B vaccine goes down. So that is why we recommend vaccination in children, because their immune status is better. So people who are vaccinated for the first time after the age of 40 are a higher risk of being non-responders. So that is why it is important to, and also it is very important that all the immunocompromised people, you give all this pneumococcal vaccine, you give influenza vaccine, but you must also give Hep B vaccine to them. And if you've given them the Hep B vaccine, after you finish the schedule, 1 month later, you must check their anti-HBs levels.
And this exercise which Dr. Tushar Shah just mentioned is for people who have not had a positive, meaning 10 plus HBsAg levels measured. If you have got one HBsAg level above 10, then you don't have to go through this exercise.
No, you can't do both. Intradermal is a fractional dose, so I don't know, maybe you could give a double dose and see, or an intradermal. Yeah, so you give normally 1 ml, which is 20 microgram, you would give 40 microgram.
Like we give in CKD,
CKD
the double
patients.
dose.
Then you know that you are a genetic non-responder, you will not respond to Hep B vaccine.
Then you stop being a healthcare worker.
No, it is also applicable for all people whom you vaccinate as adults, not as children. Because you know, in children, after you vaccinate them for Hep B, like as part of their national immunization schedule, you don't need to do anti-HBs, because most babies will respond to hepatitis B vaccine.
Okay.
Any comments on needle prick injury or exposure
Yes.
and subsequent management
Yes.
for the
That's a
healthcare
very good
worker?
question. So if you have a needle prick injury, you must first check the source for triple H. You must do HBV, HCV and HIV for that source. Now if the patient is HBV positive and you as a healthcare worker have been vaccinated and you know your anti-HBs levels were more than 10, you don't need to do anything. If you have been vaccinated but you don't have your anti-HBs levels, then you take 1 dose of you send your anti-HBs levels and you take 1 dose of the vaccine, which is a booster dose. If you are a non-responder in the past, then you would have to take the hepatitis B immunoglobulin as protection.
Okay. Since we are on post needle prick, HIV, if they get some needle prick of a known HIV case, what is the current recommendation?
So current recommendation is to start on a dolutegravir based regime. So you have Spegra or Viropil. These are 2 drugs which are like tenofovir, emtricitabine and dolutegravir. So you start it as soon as possible after exposure and take it for 28 days. But before you start this, you have to check your own HIV status. And then if it's negative, you start this and you take it for 28 days. They are very well tolerated drugs. The only thing which you have to do is maybe after a couple of weeks, you check your CBC and creatinine, just to see that you're not having any problems. And during this time, and then you would do your HIV ELISA after 3 months of exposure. Earlier, the recommendation was, now it is after 3 months.
Just once,
Just once.
3 months. Yeah, okay.
Any role for hepatitis B immunoglobulin for post-exposure? If it's a known
But if it
hepatitis
is
B
like,
positive.
yeah, that is only for those people who have not received the vaccine and who are anti-HBs negative. Because, it's a very expensive drug. Hepatitis B immunoglobulin for an adult, which costs around, I think, many thousands. So you should quickly do an anti-HBs, because many times you may not have received the vaccine, but you may be anti-HBs positive by subclinical exposure. So then you don't need to take the immunoglobulin, and you can get the anti-HBs report within 6 hours also.
So you were asking something?
Just one more remark here about rabies as well as this is, if you have given immunoglobulin on affected, if you're given on one side, make sure you give vaccine on some other limb and not on the same limb, okay?
Just one practical thing, Tushar, you might help us here because you have an OPD practice outside a hospital. Can you tell them, for those who are not giving vaccines and those who might be encouraged to give vaccination, just the storage facility that you should have in your clinic?
So apart from, I'm not talking about ideal situation, practical situation, you must have a good half-size fridge also is sufficient for you to manage. If you are going to use oral polio, that's the most sensitive vaccine and you need to be careful with that. Generally, with injectable polio usage, your oral polio usage is becoming much less. So you don't have to worry about that so much. And there are racks on which you store different vaccines. Make sure you don't freeze, just in very simple terms, do not freeze vaccines which are ready liquid formulation. Which are in powder formulation can be kept, but they are usually more temperature sensitive. So you keep it in the higher racks. If accidentally you keep any vaccine outside, you need to check what is the heat stability of that vaccine and use accordingly. Usually BCG, MMR, chickenpox, and we don't use yellow fever, but otherwise yellow fever. Of course, oral polio and rotavirus. These are the ones which we are more concerned. Anything else? More concerned about the heat stability.
And the fridge which you use for storing vaccines, you should not use for any other purpose.
Yeah.
Because, you should not open a door frequently, like you should not put food or something else in that fridge. And also, ideally speaking, there should be a temperature monitor on the outside of in the fridge, which will tell you that you are maintaining a temperature of 2 to 8 degrees centigrade.
There are self-roast company which they give you fridge with a clear glass, like how we have those Pepsi displays, and they have a temperature monitor which you can, it comes with that. Also, if you don't keep any food, but make sure you put few bottles of water inside, so that if there is accidental power cut off or power goes away, those water bottle will maintain the temperature, and make sure you don't open the fridge during that time.
And you must make sure that the switch which connects to the refrigerator now is marked in a specific way, because sometimes when they're switching out the lights, going out of the OPD, if they switch that thing off, then actually all the vaccines which may be worth thousands of rupees, you may have to kind of, discard. So you have to be very careful that that switch doesn't go off.
What I do is I put a tape on the switch. So even if I want to switch it off, I will have to make real efforts, and it will have to be a criminal act for me to open and switch it off. And if you have a central switch which trips off or which you close it, make sure that this is not included. That when you get the switch, when you get your electricals done, make sure this is out of that loop.
Any other suggestions by you as to how you maintain, because you are greatly experienced in...
One more quick thing is, nowadays the competition is so fierce now, that you will have a vendor or a supplier who will be ready to give you vaccines at short notice. So if you are not a regular user and you still need to vaccinate, You can club it, say, call all patients of vaccines on Monday or Wednesday or Friday, and have whatever who is going to come, not for pediatric vaccine, but for adult at least I'm saying, they will come and deliver it to you, and then most of them can be stored for a couple of hours without a problem.
She's asking about home visits for vaccination. How do you carry the vaccine?
So you should ideally not vaccinate patients at home.
Absolutely.
Absolutely. See, it is medico-legally not safe, because what if the patient has an anaphylactic reaction? I know in COVID times there were people and giving home, but it's not a good thing. If you are vaccinating people at home, you must have resuscitative equipment with you, so that in case they have an anaphylactic reaction, you can monitor. Now, the risk of anaphylactic reaction is very low. It is one maybe in 600,000 or something.
I don't know
We've
the
seen
number,
only
but
2 or
it's
3
there.
cases, but that can be a harrowing experience if it happens. And if you still have to carry, you can carry it in an ice box. And what I want to say is that nowadays, most of the vaccines which are available are fairly heat stable.
Yes.
So you don't have to, be very careful. I mean, even if you carry them in an ice box with ice packs, that is more than enough.
Even a simple vasovagal at home will be catastrophic for you to manage alone. So in pediatrics also, we get so many times requests to go home and do it. We generally avoid doing that.
She's saying she keeps tetanus and rabies vaccine at
she'll
home.
answer this better than me, but rabivax is very, very important, but not an emergency. Suppose somebody gets bitten by a dog in the night and you give it in the morning, should not be such a big challenge. Or you can always, what we do is sell the first dose, you go to the hospital, take the first dose, come for the remaining doses with us. And I was just talking with somebody outside that I also don't give immunoglobulin in my, or monoclonal antibody in my clinic, simply because it requires too much of human effort and the amount of noise that it generates around. So we give the vaccine and tell them to
And
finish the
you should
immunoglobulin
not keep
there.
the vaccines in your domestic refrigerator. If you're keeping the vaccines at your home, you must not be having a separate fridge. You must be keeping in your regular fridge, which is actually not recommended, because you'll be opening that fridge multiple times,
Okay, we'll go to the next vaccine and
So suppose the dog bite has occurred on the right hand and you are giving monoclonal antibodies infiltration here, then don't give the vaccine on the same arm, give it on the other arm. That's what I meant.
Yes.
All of them.
BMC hospitals and major hospitals all have rabies
So if there is a
immunoglobulin.
patient who cannot afford the immunoglobulin, you can always send them to the BMC. Yeah, he's going to come to that,
Yeah,
I think.
we'll next tackle hepatitis A vaccine. Any role in adults?
See,
of hepatitis A?
see, most of the people who grow up in India are naturally immune to Hep A by the time they become adults, but there are some people, especially if they've lived a very protected life, not had food or golgappas outside, they can be susceptible, because you do see college students and adults with hepatitis A. So actually, let us say you have a patient who comes to you for a consult for immunization, because now people have become aware of it. Then there are 2 situations where you would do. One is if you have a person who's come to you specifically that I want to update myself with all the vaccines, then you must do their Hep A IgG levels before. If their Hep A IgG is positive, then they don't need the vaccine. If they are Hep A IgG negative, then you can give them the vaccine. The other group where you would consciously want to vaccinate patients with chronic liver disease. Because if they have one liver disease, then you have to vaccinate them against Hep B and Hep A. There you would consciously want to check their Hep A antibodies, and if they are negative, give them the vaccine. So Hep A is a situation where you must do the antibody level before they give the vaccine, because most of the adults will actually be immune to hepatitis A.
Coming to, sorry.
Any thoughts on 2-dose killed vaccines versus 1-dose live vaccine?
So it's a good question that you now have a live hepatitis A vaccine, or it has been available for a long time. But one thing is that a vaccine is only approved for children below 15. And the data is not as sturdy with that vaccine as compared to the killed vaccine. So I mean, in adults, we would stick to the killed vaccine.
In pediatric also, apart from cost, at least most of us prefer to give killed vaccine because the efficacy and safety is so superior to that we don't need to change to anything else. There's no reason to change to a live one.
Where was I? Hepatitis B vaccine. I think any questions on hepatitis B vaccine, and we'll go on to the next.
Quickly about if mother's hepatitis B positive, any different thing, I'm sure that's not for them to see much,
So
but I mean.
now if you have a mother
conversion
who's
check
Hep
and
B positive, she must be referred to the hepatologist because actually they do viral loads, and if their viral load is very high, they give them antiviral drugs in pregnancy because if your viral load is very high and you're HBeAg positive, you can transmit to the baby even with full protection given. So that is the first thing. Second thing is that these babies, when they are born, they have to be given the immunoglobulin plus the vaccine, both. So that is there. So babies born to Hep B positive mothers need both the immunoglobulin and the vaccine.
Yeah, and probably this may be the only group in pediatric where we would check the conversion after the course is over.
In fact, you
That was
would
a question
check
by
their
somebody.
surface antigen also because sometimes despite the best, you may still get infection. So ideally after you finish their course at 6 months, at 9 months, you would do their surface antigen and you would do their anti-HBs both.
Question to all of you. Which acute viral hepatitis is the commonest in adults? A, B, C, D, E? Which one? E is the commonest in adults. Is there a vaccine against E? There is a vaccine against E made in some countries. China has it. Some Asian countries have the vaccine against E. Not yet available or approved in India. And we don't know whether the E vaccine will come. But index of suspicion in adults, the commonest age group is 15 to 35. The index of suspicion in adults who come to you with elevated enzymes, not even with clinical icterus, you must test for anti-HEV IgM. That is the test we do, anti-HEV IgM, because subclinical mild hepatitis E is not uncommon. Any thoughts on adult hepatitis E that you see?
I mean, it can be fulminant, especially in pregnant women. So that is why it is very important to counsel pregnant women about hygiene related to food and water. Because if they get Hep E, then their chances of going into fulminant hepatitis, death, and their babies dying is very, very high.
Nearly 20% mortality
Is
in
there.
pregnancy.
So pregnancy, it should be a routine thing that don't eat food from outside and be careful. That is very important. And otherwise, unfortunately, there is no specific therapy. Ribavirin is being used in some patients, but it is a bad disease if they go into fulminant hepatic failure.
And the thing about hepatitis E is that if you have had hepatitis E once, we don't know whether you can have it a second time. You probably can. So it is not a lifelong immunity.
Because there are many genes of the Hep E virus actually. So that is why.
Right. She's asking anti-HBs, how frequently should we check?
Just once. Once you've done your vaccination schedule or you've taken your booster, you do it once. If your anti-HBs is more than 10, you never need to check it again. Because it may decline over time, it may become negative, but you will still be protected. The only situation when you need to check it again is if you become immunocompromised for any reason, like you get a chronic disease or you are on immunosuppressive drugs, then it is recommended that these people periodically check their anti-HBs levels, and if their anti-HBs levels have fallen below 10, then they take booster.
Any other question on vaccination in general? Because I think we are done with vaccinations. Typhoid, sorry, one typhoid vaccine left. She's
What
asking
should be kept
if he keeps vaccines in the clinic, what resuscitative equipment should he keep? Is that right?
Yeah.
What he should keep in the clinic?
So, yeah, I mean, I would answer that as by saying that what I do is in my injection tray itself, I keep 2 or 3 ampules of adrenaline and I put a small sticker because the adrenaline has a notorious habit of short expiry. So I put a sticker over there saying the date. So I know that this date, because God willing, thankfully, I don't have to use them. And so when you need it, it might be expired. So that's one point. Second, you must have ideally you should have an oxygen cylinder, bag and mask, and a saline bottle and a IV set or infusion methods. At least this much you should have. Anything else?
No, perfect. You must know the dose of adrenaline, 0.06 ml per kg or 0.5 ml IM.
Yeah, correct. For kids, yes. For adults, if you're giving, you give the full ampule. Yeah. Efcorlin, you can keep it, but Efcorlin doesn't come under the resuscitation protocol.
Avil, Efcorlin, yeah, these are the drugs, but they're not
Efcorlin,
part
you
of
can
the...
definitely have it. I'm
Our
sure
job is to give adrenaline, intramuscular, immediately. That is
even
our
if you
job.
don't have oxygen, it doesn't matter. If you have good bag and mask, even if you don't intubate, doesn't matter. You should have adrenaline and you should be able to do bag and mask. Most of them can be managed on that.
Also, he said oxygen cylinder. Now we have oxygen concentrators. I have one in my clinic. COVID gave us a few thousand extra oxygen concentrators across the city, right? Beg, borrow, steal. You will get an oxygen concentrator from somewhere. And please keep one concentrator if you can, at least in your clinic.
Also, rather than keeping the standard big oxygen cylinders, now there are small oxygen cylinders available, so-called portable, which are around 10 kg in weight. So if you have to transport the patient also, if you have that, that lasts for about I think 1.5 to 2 hours. So you can reach the hospital with the patient, at least in the pediatric age group, with that oxygen cylinder and a tube and a mask. Yeah, but smaller will not last you to reach up to there, that's why. Yeah, whatever. So basically there is a portable available which you can have it with you.
Dr. Hiret, he's asking why has medicine not come out with a HIV vaccine?
I don't know actually. I have not gone into the basic sciences, but they've tried a lot and they have not been able to find a suitable candidate. And in fact, a couple of trials showed that the people who received the vaccine had a higher risk of HIV. So somehow, and it's perfectly fine because there are so many diseases for which they've been trying for a good vaccine and they've not got. HIV is one of them. Malaria, you have a vaccine now, but it is not the best of vaccines. Similarly, dengue. There was a dengue vaccine which came, which had problems. So now people are looking at a different dengue vaccine. So RSV is another infection against which they've not been able to develop.
He's asking if a child has become 6 years old and has not received vaccines.
So
What do you
then
do?
this is like a catch-up vaccine and the most important vaccine for this child is MMR. Okay, that's the most important vaccine. So at the first time you would give the child MMR, you will give him his, what you call as the triple with IPV, Hib and hepatitis B, the hexavalent vaccine you would give. And then you would give maybe typhoid, you could give chicken pox all at one time. So remember that you can give all these vaccines together and then after 1 month you would give the antigen again, you would give a second dose of MMR and chicken pox and then at 6 months. So you can finish all the vaccines in 3 visits at 0, 1 and 6. But if you have to prioritize the vaccines, then I think MMR is the biggest priority because that can be a very bad illness. You can give 4 or 5 pricks also. I mean, it's a little too much for the parents, but you have to tell them, see, the child will eventually need 4 pricks. Now, whether we give them all on one day or you keep coming with the child to give a separate prick, the pain is going to be the same.
And when you have to use more than 2 pricks, then you can tell them that you will give it in the gluteal region, the subcute ones, so that you are not compromising. Suppose they say, no, we don't want to give over here. We would still give it in the deltoid, and all you need to do keep a 2-finger gap. That means a 5 centimeter gap between the 2 injections. Make sure that your direction of the needles are not crossing each other, kind of precaution you have to take. And that's all the care you have to take.
BCG you would not give if the child is more than 5 years of age, yeah. Otherwise, all other vaccines.
Rubella vaccine for young girls.
So if the girl has received MMR as part 2 doses of MMR at 15 months or 9 months or 5 years, then they don't need catch-up rubella vaccine. This is only for those people who have not received MMR, and you don't need to check their rubella antibodies. You can just give it because the vaccine is cheaper than the antibody test. So you can give MMR because you don't get standalone rubella vaccine. So you give MMR instead.
Your RVAC and MR used to be available earlier, and MR currently is only used by the government because for them the cost is important. For us, MMR itself is not so expensive. So whenever need be, just use all three of them together.
No, they don't. So if you know that, I think 1 dose is good enough for rubella, 2 doses are good enough for mumps and measles. So if they have received that vaccine, then they don't need a catch-up vaccine.
Now we go to the typhoid vaccine. The typhoid vaccine, as we know, a conjugate. We'll take it in a minute. Typhoid vaccine is the conjugate vaccine. As you know, a new vaccine is available. EnteroShield is one brand name. TCV is another brand name. Both manufactured, I think, by the same company, Serum Institute. So typhoid vaccine now is being recommended.
It's by Bharat Biotech.
Sorry, Bharat Biotech. I'm so sorry. And yeah, so what is your recommendation? Up to what age can people get typhoid vaccine?
So, you can start at 6 months now. So, because earlier the unconjugate vaccine you had to give at 2 years, but now you can start at 6 to 9 months. So, we typically give it at 6 to 9 months. And studies show that 1 dose of the vaccine is good enough. Like earlier they used to say that you give every 3 years. For the conjugate typhoid vaccine, single dose is enough. The question is, till what age can you give catch-up vaccination against typhoid? Now, the vaccine has been licensed till age 45, the typhoid vaccine. And you do see typhoid in adults as well. So you can offer typhoid vaccine as catch-up vaccine in adults also. You can give it.
Absolutely.
But I just kind of want to understand from you, do you see typhoid beyond age 45 or something?
So I have kept my limit as 35. But yeah, 45 is recommended. We are not seeing much typhoid in older adults. So in fact, it doesn't even come in our differential diagnosis often. And yeah, so I think the older you get, the better it is.
Because what happens with typhoid is that every time you get naturally exposed, you get immune. And as you grow older, you have had so many exposures with Salmonella typhi or paratyphi in our country that you get immune.
And as Dr. Vasan Nagukar last time said, there is a decline in pure patch thickness, lymphoid tissue. So the typhoid bacillus does not have place to kind of make residence.
But if somebody has had typhoid, should they take typhoid vaccine again?
Yeah, this is unfortunately not been answered scientifically because most people have just one episode of typhoid in their life. I mean, they may have a relapse, but they don't get secondary infections. But if you look at the guidelines by IAP, they say you must take one vaccine after recovery. That is there. So, but we don't know whether it's really needed or not. That answer is not clear.
And again, when the patient says he or she got typhoid, means whether it was a culture-proven salmonella infection or whether it was typhoid-like illness, that can be there. So that's why it's just better to vaccinate everyone who is willing to get vaccine.
There is no relationship. The people
He's asking about vaccines and autism in general. And
no relationship. In fact, that doctor who actually wrote that paper on MMR vaccine and autism, his license was taken away. He's not practicing. So that was a false paper. So we have to counsel people because we see it all the time that there is one child who's autistic in the family, which has become quite common. They don't vaccinate the other kid because of this risk.
yeah. TCV, he's saying, are 2 doses required in early age especially?
No, not really. Actually, that was earlier thought, but now I think 1 dose is enough, na? The new guidelines.
Yeah, the new guideline says 1 dose is enough. Some of the pediatricians are still using 2 doses because, like how all LICs and everyone has a small asterisk, it says till further information is available, 1 dose is enough. So many people feel that till that confirmation comes, we will continue to use 2 doses. So
Adults, definitely 1 dose. Have IAP guidelines of 23 come?
Not changed, not like a newspaper, don't worry. The last one,
The last one, whichever
last
is
one,
available
whatever
on
is
the
available.
IAP website.
And the last one and the one before that has said that TCV 1 dose is enough. Even WHO guidelines are one.
Sorry, later.
TAB is not available at all. For
TAB is
20,
not
30
available.
years, it's not available. Huh?
No, what you are saying is a VI vaccine available. Yeah, VI is different than TAB.
That is for the VI vaccine. Yes. So the cost is 300, 350, and whereas this is 1500, so you can use VI polysaccharide vaccine also. And you know, even that guideline of it being used every 3 years is not evidence-based. There is no study which has been done. It is just an arbitrary guideline. So, but you assume that if it is an unconjugate polysaccharide vaccine, there is no immune memory, so you would need to revaccinate. Oral. That is not available in India now because the cold chain requirements were rigorous, so that oral vaccine is not available.
Okay. Huh? I'm sorry. Vaccination done. Anything left in vaccination, especially adults? Rotavirus.
It's only a pediatric vaccine, but it is, remember that the final age till which you can give the rota is 8 months. Beyond that, you can't start rotavirus vaccine. And you have many brands available, Rota Tech, Rotarix, and you have Indian brands available like Rotavac, Rotasil. So they are, most of the time same. So you have to give 3 doses except for Rotarix, which you have to give 2 doses. But remember, there is an upper limit to vaccination with Rota.
Recommended to every child below 8?
Yeah. And now it is part of the government program also. So the government is also giving rotavirus vaccine and pneumococcal vaccine.
Okay. One vaccine that we know is given to travelers is the yellow fever vaccine. Is there some change in the norms of yellow fever vaccine?
I think earlier the requirement was that every 10 years the vaccination certificate is valid, but now it is believed that once is enough. Yellow fever vaccine, and it is not available commercially. You have to go to the airport and take the yellow fever vaccine, and there are certain exceptions like children below the age of 6 months, people above the age of 65, people with HIV, people with thymic disorders, or they cannot take the yellow fever vaccine because it's a live virus vaccine and you can actually get yellow fever disease because of the vaccine.
So all those of you who have a yellow fever vaccine certificate, there will be date mentioned on that certificate valid up to so and so year. Now remember that that date has no limit now. So you need not take the second dose and you can still travel showing that old certificate. Cholera vaccine.
So cholera vaccine is basically a oral vaccine which is available, Duke Oral or something it is mentioned, but it is not a vaccine for regular use. Unless you are in the middle of a cholera outbreak. So it is not a vaccine which you would routinely give to people. If you have a person who's going to a place in Africa where there is an ongoing outbreak, you would consider giving it. Otherwise, it is not a vaccine for regular use at all.
So both meningococcal vaccine.
So meningococcal, now we use only the conjugate vaccine, okay? Meningococcal, which is like quadrivalent, and there are 2 brands available, one from Sanofi called Menactra and one from GSK called Menveo. And these vaccines are being promoted for use in healthy children, but there's no real data about that. IAP is not recommending the use of these vaccines to healthy children because the burden of meningococcal disease is not huge and because these vaccines give only protection for 3 to 5 years. So the people where you would give meningococcal vaccine is either splenectomized people because there the risk of meningococcal disease is high, or people who are traveling to endemic areas like Africa or going for Hajj, or you would give it to students who are traveling to the US because it's a requirement there that you have to give the meningococcal vaccine, and there are meningococcal B vaccines also available which are not available in India. But if you are studying in the US, then some of these students need to take the meningococcal B vaccines over there.
Some European countries have Men B as a requirement in children also, which we don't give. So please don't put a date and sign in front saying it's been given.
So I think, it's not a vaccine for regular use. You would give it only in special populations, and that is also for JE Japanese encephalitis vaccine, you know, that is also for specific areas in India. You don't need to routinely give JE.
Yeah. Unfortunately, you might have a medical rep who will come or a vaccine representative will come and show you a map of India, which is very nicely colored, which has many areas and districts which are shown as endemic.
Endemic
But
for
endemic for
Japanese
JE or
encephalitis.
endemic, mainly for JE, means even interior of Maharashtra, some parts of Andhra, a lot of other areas are being said. And so a lot of people, pediatricians also use JE routinely. And
Yeah, because the thing is that there are two types of JE vaccines. The government, where it feels JE vaccination is important, gives a live subcutaneous vaccine at 9 months of age, which gives long-lasting protection. That vaccine is not available commercially. What you have is a vaccine called Gensivac, which is only a vaccine 2 doses given 28 days apart, which gives protection only for 2 to 3 years. So obviously you are not going to keep on vaccinating these people, you know. And the risk of JE is more in rural areas, not so much in urban areas. And you know, people will say, I saw one case of JE. The patient got it in Bombay, but please remember that you will not start vaccinating for that one-off thing that you've had. Na? There has to be a certain burden for which you can vaccinate, because otherwise you can't protect all diseases. I mean, you know, just for one case that you've seen, you won't start giving the JE vaccine to everybody.
And we also have this FOMO of saying that somebody else gave it and my child did not get it. My other pediatrician, somebody gave it and you don't give it. So how do you
In
tackle
fact,
that?
if you see people coming from the north with their immunization cards, there will be meningococcal vaccine routinely mentioned in there. And we sometimes say that we are not recommending it routinely. But if the parent demands it, then you have to give, because God forbid tomorrow there is a meningococcal illness which the child has, then you have a problem. But you will say, and you can say that our guidelines are there because you are safe, because you have a IAP guideline that yes, this is not a vaccine recommended for general use, because somebody may turn around to you and say that you didn't give me the vaccine. But you have saying that, you know, our guidelines don't recommend it.
He is asking, after vaccination, you ask some people sometimes to wait in the waiting room. Is it all vaccines or some vaccines?
Actually, all vaccines, you should ask them to wait for 30 minutes, because sometimes you may get a reaction. And the other thing about HPV is the syncopal attack, because you know it is usually given in adolescent girls who are anyway like that. So you have to give the vaccine in a sitting position. You have to keep the child sitting for some time before you ask them to get up. But otherwise, for all vaccines, as a rule, you must ask them to wait for some time. Maybe not 30 minutes, at least 10 to 15 minutes.
Yeah,
What
we
do you
tell
say?
them, but you know, like how all of us took COVID and we sat in the next room counting 30 minutes, and at 29 and a half, we are up and waiting at the door. Many of them walk out, but it's a good idea to tell, at least for HPV patients, we insist you wait for 20 to 30 minutes. And then if they go away earlier, then that's all right.
Okay, yeah, Anuj? Ovarian failure due to HPV vaccine.
No, I don't think. There are lots of trials, and they have now 20 years data before when the HPV vaccines came. There is no data to support any kind of autoimmune process or ovarian failure because of HPV.
And even HPV-9 is more than 5 years old in US, and they have very robust data on HPV-9 safety-wise.
She's asking if not more than 4 vaccines can be taken in one day in pediatrics. Should we take a gap of 1 month or can we call
No,
earlier?
you can give it the next day or after a week, with the exception of MMR and chickenpox. So you can either give MMR and chickenpox on the same day or 1 month apart. But apart from that, all other vaccines you can give at any time interval from the previous dose.
Okay, I think vaccine
If they've taken yellow fever vaccine, make sure you wait for 1 more month before giving MMR or chickenpox. Again, the same principle of live vaccine.
Okay. Any questions? I think the one topic that we had wanted to discuss was tuberculosis. We have some time, 15-20 minutes. Are you okay or you're sleepy? Yeah. So we'll discuss tuberculosis. First of all, tuberculosis ka investigation. I don't know if there is resistance still to do sputum AFB, gene export, etc. What is your
See, we
take
must
home message?
move to one important concept, that you have to try and prove the diagnosis of TB microbiologically. You have to at least try to do it. Now, it's possible that even after doing all the investigations, you may not be able to do it, but that attempt should be there. So you have to obtain a relevant specimen depending on the site of TB you are suspecting. So if it's pulmonary TB that you're suspecting, you have to get a sputum test. If you are suspecting lymph node TB, you have to get a lymph node aspirate. If you are suspecting spine TB, you have to get a biopsy from the spine. The problem comes in patients where there is no ready sputum available. Then they think, oh, we don't want to do bronchoalveolar lavage, we don't want to do biopsies. There is a problem with that because one, you may have TB mimics, which you may miss if you're not doing those invasive tests. And second, because we are a hotspot for drug-resistant TB in Bombay. So it's possible that your patient may have drug-resistant TB and you may not be able to diagnose it. So I think a general principle is you have to try and make a microbiologic diagnosis.
So we must tell them the statistic of first-time TB incidence of MDR, drug resistance.
So at least in Bombay, it is believed, like overall in the country, it's said that 3% of your first TB is MDR and maybe 15 to 18% of your previously treated TB is MDR. But I think in Bombay, it is about 10%. That primary MDR rate in Bombay is quite high. So even if you have a patient who has not been treated for TB in the past, who has not been exposed to a family member with MDR TB, they can still have MDR TB because they got it from the train or the bus, we don't know where.
So there are two things to unlearn. One very basic thing to unlearn is, in the past decades, we used to give empiric TB medicine for prolonged pyrexia. Now that is gone. That you cannot even think of giving. 3-4 weeks of fever, no investigations positive, let us try a TB trial. That is gone. You cannot, it's criminal. That is one thing. And second thing to unlearn is, you see an X-ray looks like TB, and patient has come with fever of 3-4 weeks. You must still get a microbiologic diagnosis because X-ray can be sarcoid, it can be so many other things, but you must get a microbiologic diagnosis. So now about the sputum testing, which is the commonest what test should they do? Gene expert, AFB, culture?
So sputum now, early morning is better. Like somebody asked urine culture, what is better? Morning sputum, because that's the maximum you can get. And you have to make sure it's sputum and not saliva. Because many times people are coughing and you ask them it's a frothy fluid, it's saliva, which will not give you anything. So it should be, quality should be good. And that sputum should be sent for AFB smear, for CB NAT, and for TB culture. All three tests have to be done on that sputum sample.
CB NAT is the amplification test, which is
Gene expert, because
also
CB
called
NAT
gene expert.
can be done by various methods. One is gene expert, then one is true NAT. In the government, they do true NAT. So a cartridge-based amplification or a PCR test you have to do. Yeah, so nowadays actually the guidelines say, earlier they used to say that you take 3 samples. Now even we say that you do a 1 sample. If your sample is negative, then you can attempt 1 more. But 2 samples is the max that you do. You don't keep doing 3 times. And you should try and see how you can get a better sample. Because if the first sample, it was negative, it may mean the sample was not adequate. So you can do induced sputum, give hypertonic saline nebulization, ask to cough, and then collect the sample.
So should CB NAT also be repeated?
Yes, so actually CB NAT ke liye the guidelines say only 1 sample, the others. But sometimes, if your first test is negative, then you could make 1 more attempt on a better sample and do a CB NAT. Because of course the cost would increase. But if you pick up TB, then otherwise you will have to go down either empiric therapy or you would have to do a bronchoscopic lavage in adults.
How to interpret a CB NAT or a gene expert report?
So you will see 2 things in the gene expert report. One is MTB detected or not, and rifampicin resistance detected or not detected. And then you will have a third component of low, very low, medium, high. That is the load which is there. So remember that if your sputum shows MTB detected, it is TB. Whether it is very low, whether it is low, it doesn't matter. And then the second thing is rifampicin resistance, detected or not detected. If it is detected, it means your patient has MDR TB. If it is not detected, it means it is drug sensitive TB. Now, I mean, there are some situations where you may have drug sensitive TB and yet your report may show drug resistant, but let's not talk about those areas. Because sometimes, you know, people say, "Arey, this is very low. Does it mean that I have very low TB? No. It means very low means you have TB, even if it is very low.
Should we tell the family physicians not to treat drug-resistant TB at all?
Absolutely. Even I don't treat drug-resistant TB now because the government has now oral drugs for DRTB. So you have to send them to the government because they will give bedaquiline-based therapy, which is more effective and less toxic than the other therapies which used to give. So DRTB is not even in the domain of infectious disease specialists now. It is with the government.
How much does the gene expert cost in private setup?
I think 1800 or something. So that is the cost, but you have various government places which can do it free for the patient.
Yeah, so just send it to Cooper Hospital or any other hospital nearby. Yeah. But remember, when you send them, it's my personal experience, once you send them, your prescription will have your name. They will put their name. If you start the treatment, you will get, once that patient's test come positive, you will get a message saying that your patient's tested positive. Please contact them, and you make sure that you report that patient. Okay, it's very important, and you don't have to, like olden times, you don't have to fill up the form, go to the BMC and submit. Just call up or put an email. I prefer to put an email to your ward officer, and then that NICSHA registration will happen.
So even before the patient comes to know that they have TB, they get a call, you know. They are capturing from everywhere. Even if there are patients, they are capturing from where the TB medicines are being dispensed. That is also reportable. So and the BMC is doing a job of following these patients, making sure they take their medicines and everything. So
every patient gets 500 rupees directly into their account if they don't have to travel for food and nutrition. And if they are far away, then they can get 1,000 rupees for travel and food and nutrition. And just by putting their Aadhaar card number, they get the money in their account for next 6 to 9 months. Doctor also gets 500. If you have reported, you also get 500. Now that's important. The idea is that they give you 500 rupees, but they make sure that if you don't report, you can be penalized in a much worse form. NICSHA.
Yeah, NICSHA. So NICSHA is an ID system in which you can also register at NICSHA and directly report, because for every patient who is diagnosed with TB in the country, an ID is generated. So that remains in their records forever. Everything is through NICSHA. 3%.
He's asking hypertonic saline, how do you use it in
And you know,
nebulization?
one more thing you have to understand, that please don't ask the patient to cough in front of you and collect the specimen, because you can get it. So you have to be very careful. Ideally, you should ask the patient to collect the specimen at home and bring the thing, not even do it in the OPD, etc. But if you are doing induced sputum, then you have to have a room with the exhaust. You have to wear an N95 mask and then collect the specimen. It is because otherwise, if the patient is coughing violently in front of you, you can get infected.
What do you do with other family members if one has been detected with TB? Or how do you screen them?
Good question, because now the government is paying emphasis on treatment of latent TB. So as per new guidelines, all family members or household contacts have to be screened first for active TB. Means you check with them, are they having fever, cough or something. And if they are having, then they get x-rays done, because then you treat them as TB cases. But suppose they are not having symptoms or signs of TB disease, then it is recommended that all children below the age of 5 years be put on prophylaxis. INH for 6 months. It is mandatory, because these are the children, if they get infected, they are at risk of disseminated disease. Above the ages of 5, their guidelines say that you can actually test them for latent infection. You can do either an IGRA or a MANTU test, and you can give them prophylaxis if they are IGRA or MANTU positive. And that applies to adults also now. That even adults, like suppose a husband has TB, the wife is with him, the wife doesn't have symptoms of TB, but she's IGRA positive, there is a provision to give her chemoprophylaxis to prevent, because you will often find people that 3 years ago, ek jane ko TB hua, now somebody else comes with TB, and it could be because of the infection which they caught from their... No, you will test when you may diagnose TB in the person.
So is this the correct protocol? One index case has TB proven, 5 family members, all 5 screen for symptomatology, X-rays done in adults, all maybe MANTU in children. Is that right?
I mean, no, for children below 5 years, you don't need to do anything. You know, you just don't even need to do a MANTU. You just give them
Give them 5
chemoprophylaxis.
to 12.
5 to
He's
12.
saying to rule out active disease, whether you should do.
So, actually, X-ray is not mandatory to rule out active disease, because most of the times if you see X-ray reports, what are they? Prominent bronchovascular markings, haziness seen. So that is actually maybe make you this. So that is why we don't recommend X-rays, at least in children. You know, you would, and it's radiation exposure. So a symptom screen is enough. That if they have fever, if they have cough, you examine their chest. If they are otherwise fine, their growth is fine, you don't need to do X-rays to rule out active TB.
Okay.
So only right now the national guidelines are NH for 6 months, but soon you will have other regimes for chemoprophylaxis, which is rifapentine and INH. It is coming in the program where you only have to give single dose every week for 12 weeks. And that is enough for chemoprophylaxis. So that is actually a good thing, because you know, who would want to take medicines daily for 6 months? So here it is just INH at a dose of 15 mg per kg plus rifapentine, which is a long-acting rifamycin, and you give it weekly for 12 doses, and then your chemoprophylaxis is over. I think the government will bring it in a big way, because our aim is to eradicate TB by 2025, which is not possible, or 2030. So unless you take care of this latent pool, you may not be able to do that. So soon you might, and actually if you send these patients to BMC, they have a cell now which is looking at chemoprophylaxis, and they might offer INH and rifapentine, because this INH rifapentine is not available commercially to us. You can't buy it in the market.
Role of MANTU test.
Actually, you know, it is, one is that MANTU test, ek to wo, that tween 80 is no longer available properly with PPD RT23. Then you have to do a MANTU with 1 or 2 TU. Many times in labs, they do 5 TU or 10 TU. Remember that MANTU test or IGRA have no role in the diagnosis of active disease. Absolutely no role. The active TB diagnosis is by the symptoms, radiology, and biopsy and microbiologic diagnosis. You cannot do MANTU or IGRA to rule out TB also. That your patient is having fever for 3 weeks, you do IGRA, IGRA is negative, means it doesn't have TB. It is of no role. So remember that these tests for latent infection are only, these are only tests for latent infection. They have no role in diagnosis of active disease. Huh?
Does a negative MANTU have a role in ruling out TB?
No, because 20 to 30% of patients who have disseminated TB will have negative MANTU. So neither does it help you in ruling in disease, neither does it help you in ruling out disease. IGRA, so you can do it as a replacement to MANTU. So suppose you have a household contact who is above 5 years old, and you want to check whether there is latent infection or not, because the guidelines say that you would give chemoprophylaxis to a household contact only if they have latent infection. Yeah, if you want to consider them for chemoprophylaxis, so you can do IGRA for all the 4 adult family contacts. No, you can do it immediately. Of course, some people say that you should, you know, it takes time after you've got infected for an IGRA to be positive. But please remember that patient who has been diagnosed with TB has been having symptoms for maybe 2-3 months. Then they become diagnosed. So you can do it IGRA at that point in time. If the IGRA is positive, then you can offer them chemoprophylaxis. INH for 6 months, 300 mg daily with pyridoxine.
IGRA, I have never asked for an IGRA. What is IGRA, and what is latent TB? What is the meaning of latent TB?
See, latent TB, you must understand the pathogenesis of TB, that TB bacteria enter our body. They are there in our lungs. They are captured by the reticuloendothelial system. They also travel to various parts of the body. Now, in 90% of the cases, this TB bacteria don't cause disease because our body's immunity is enough to take care of them. So they remain as latent in our body, but they have the potential to reactivate at any point in time, most within the first 5 years after infection or during lifetime, and cause active disease. So when these TB bacteria are inside our body and they are not causing disease, they are called as latent TB. Now, how do you diagnose if a patient has latent TB? You can do it either by the Mantoux test or by IGRA. In Mantoux test, what you do is you put the tuberculin antigen in the skin and the lymphocytes and all come, and you have an induration which is more than 10 mm. In IGRA, what you do is that you collect the blood of the patient and the lymphocytes are stimulated with the TB antigens artificially. You expose them to TB antigens and see what is their production of gamma interferon. And if that gamma interferon is present, it means your lymphocytes have been exposed to TB bacteria in the past. The advantage of IGRA over Mantoux test is that Mantoux can be positive even because of previous BCG, whereas IGRA is more specific. The problem with IGRA is that sometimes you get indeterminate results. And also another problem with IGRA is that the labs have to immediately process the sample, and if you are not processing it immediately, then you may get a false negative result. So the advantage of IGRA is that it is a one-time test. You don't have to call the patient back. It is specific. But the downside is that it is more expensive than the Mantoux.
Sorry, TB Gold is synonymous?
Yes. So IGRA is available as different types like TB Gold or Quantiferon Gold.
Yeah. May I just continue on this? So again, latent TB is when you have TB bacilli which are not causing disease. My question, which I am a little ignorant about, is I have TB bacilli. My brother does not have TB bacilli, latent TB. My third brother has active TB. Are you saying that the person with latent TB is more prone to catch it from the active person than the person who does not have TB at all?
No. We are saying that the person who has latent TB has probably got infected from the index case and is at higher risk of developing TB later. That is why you give chemoprophylaxis, whereas the person who is negative for latent TB does not have the bacteria in his body yet, but may get it at any future time. But for now, he's not a candidate for prophylaxis because I'll tell you the downside of prophylaxis, that first, it can have side effects like jaundice and peripheral neuropathy. The second problem in India is that, in the US, you are not going to get exposed to TB again and again because the burden is low. Now, India is an endemic country. Today, you may get exposed from one family member. 5 years down the line, you may get exposed from somebody else. You can't keep taking these chemoprophylaxis regimes again and again. So that is why we really don't know whether treatment of latent TB is such a great idea in our country, which is endemic, but for now, the government says that we should treat it. Now, there is another situation, like suppose somebody doesn't have any active person with TB in the family, but has just gone ahead and done an IGRA. Now, maybe he was having prolonged fever, so somebody thought that I'll do IGRA. Now, he doesn't have TB, he has some other cause of fever, but IGRA is positive. Now, should that patient be given chemoprophylaxis because he's IGRA positive? The answer is no. Why? Because you could have become IGRA positive because you were exposed 10 years ago. And you know that the risk of active TB is most in the first 2 or 3 years after you have got infected. Now, if you have a family member who is infected, the chances are that you have got recent infection because of which your IGRA is positive and you are at a higher risk to develop TB. So you must understand there are a lot of ifs and buts around this, but for simplification purpose, at least for children, we must consider them for chemoprophylaxis, especially children below 5 or other children, because their risk of converting from latent disease to active disease is higher than adults.
So should we be giving the same latent prophylaxis for index cases, suppose it's a lymph node or a bone TB versus?
It is only applicable to infectious pulmonary TB, so that's an important point. So that index case, suppose the index case has spine TB, and the chest X-ray is normal, then the family members are not candidates for prophylaxis.
He's asking if the index case is MDR, does INH prophylaxis
No,
work?
no, it doesn't. So in that situation, till now the guidelines were that don't give any prophylaxis, okay? But now they are saying that if the index case has quinolone sensitive drug-resistant TB, then you can give levofloxacin for 6 months to the contact. But if you see most of the patients in Mumbai, their TB, MDR is resistant to quinolones, then you can't give it. But otherwise, levoflox for 6 months.
Interesting. Yeah.
No, so it's an important question.
The question is, does IGRA become negative after 6 months
6
of
months.
INH?
No, no. So remember that once you have the MAN2 positive or your IGRA positive, it never becomes negative. So you should not look at doing it repeat to see if it is negative. Of course, it for technical reasons it may come negative. That is a different matter. And also, if one person has been IGRA positive in the past or MAN2 positive in the past, you are not going to repeat his IGRA or MAN2 again to make that decision. Or if there is a patient who has a family member who has already been treated for TB in the past, then now if he is exposed to a family member who's having active disease, that patient does not qualify for chemoprophylaxis.
Just one question from me. Do we have now good studies to show that INH prophylaxis reduces incidence of future TB over how many years?
Yes, so studies show that there's a 90% reduction in active TB with INH prophylaxis, and
Below
that
5
is
years of age.
no, this is in
Adults
adults.
also.
Adults. So it is there. That is why the drug which is the gold standard for latent TB prevention is INH, because we have clear studies documenting a decreased incidence of TB. But the issues in India are different because we are endemic, So, I mean, you may now treat for exposure now, but after, if you're exposed again after 6 years, will you treat again?
Ma'am. If sputum is not available, so the two options that she gave was nebulize with 3% saline or do a bronchoalveolar lavage.
So that we do in children. So we do it in children that if they are not bringing out sputum, then we either do a gastric lavage or an induced sputum. Actually, I've had adults where I've done a gastric lavage. So sometimes you have a sick adult admitted in the ICU with suspected TB. Many times you get a gastric lavage also, which is positive. But I mean, for the general OPD patient, if the sputum is negative, you should recommend a bronchoalveolar lavage. But I must tell you that all patients may not agree for a bronchoalveolar lavage. So there is a situation there where you can consider empiric therapy, and what you can do in such patients is you can get a CT scan done, because a CT scan is better in telling you about the morphology of the lesion. So many times you have patients who have come with fever, the chest x-ray shows a lesion, now you do a CT scan and it shows necrotic mediastinal lymph nodes and nothing much in the lung parenchyma. Now this is a patient where you either have to do a CT guided biopsy of the lymph node, or you have to and because BAL may also not pick up because it's not in the parenchyma. So this is a situation where you may consider empiric therapy, but you must try and get a microbiologic diagnosis. But I must tell you, there are patients where either you can't do an invasive test or you do the invasive test and it is still negative. Please remember that of your whole cohort of TB patients, only 50% will be positive by gene expert and TB culture. The rest of the 50%, you will have to treat empirically based on your clinical presentation, your radiology and other things.
What is the current regimen for rifa-sensitive TB?
So current regime is 6 months therapy with 2 months of intensive phase with INH, rifampicin, pyrazinamide and ethambutol, and 4 months of INH, rifampicin and ethambutol. So the new regime says you continue ethambutol also in the continuation phase.
I think any questions on TB?
And again, the dose is very, very important, because many times, people just write AKT4. Now, AKT4 has only 450 milligrams of rifampicin. It has adequate amount of pyrazinamide, but less of ethambutol. So that 450 dose is only adequate for a person who is about 50-52 kg. Above 55 kg, they must get 600 milligram of rifampicin. So we must use the proper drug doses. In fact, to the extent that a patient who is above the weight of 75 kg needs higher dose of INH of 375 mg, and as per the government program, they get 750 mg of rifampicin, and maybe up to 2 grams of pyrazinamide and 1600 of ethambutol. So even in adults, you have to be careful with the dose. You cannot use the same dose for every adult, because some of them may be weighing 40 kg and some of them may be weighing 80 kg.
You know that mg per kg, 5, 10, 15, 25. 5 mg per kg INH, 10 mg per kg rifampicin, 15 mg per kg ethambutol, 25 mg per kg pyrazinamide. So you have to stick to that. So fixed dose combinations are a problem.
20 milligrams. Yes.
If radiology or necrotic lymph nodes are there.
Yeah. So, no, because you can't. It's like it's a utopian thing,
When
that
I
dream.
said first time that you don't give empiric, I meant in prolonged pyrexia, where there is no radiological or clinical evidence of TB, you should not give.
See, I would not stop at an X-ray in this era, because see, now CTs are so available and people can't say that CT is expensive, because we were doing CTs left, right and center for COVID when it was not indicated. So I think you must, at least in a prolonged pyrexia patient, you must do a CT scan, because many times it will show you necrotic nodes, etc., either in the chest or abdomen. Then if you can't do a biopsy, if the nodes are not biopsyable, or you've done a biopsy and it is negative, then you may start.
You can start. I think, sorry? What is the role of steroids in tuberculosis in general?
So only in certain specific situations like TB meningitis, that's an absolute indication for steroids. Then other indications are pericardial TB. They are mainly the two indications. People commonly use steroids for pleural TB, it's not indicated. They use it for peritoneal TB, it's not indicated. Then in miliary TB with hypoxia, you can use. So there are very 2 or 3 indications, maybe TB meningitis, or a patient who has tuberculomas with lot of perifocal edema and raised ICP and midline shift, you can use there, or in pericardial TB use.
Maybe spine TB with compression.
With compression. The danger of using steroids is, many times patients come with pleural effusion. You do a pleural tap. Gene expert is almost always negative in the pleural tap. Patient is started on AKT and steroids. The patient is very happy because the steroids have helped in bringing the fever down the next day. But the problem is, if your patient has MDR TB, you will not come to know about it. So, and pleural TB is not an indication for steroid therapy. Many times, patient is having TB, you're giving TB medicines, 2 weeks stuck, the fever is not coming down. Patient is frustrated, my fever is not coming down, my fever is not coming down. Then we add steroids to bring the fever down. That should not be done, especially if your TB was not microbiologically proven. Of course, there's another indication for steroids which we call as a paradoxical reaction, which often happens in TB, that you've started TB treatment and after some time the patient is worsening, it's not drug-resistant TB, then you can use steroids. But steroids should not be used as antipyretics.
I think we'll end here. And we'll, of course, first give her a round of applause for the brilliant, sorry. Yeah, this is not usual to get a standing ovation. So, and a small token from us. Just a box of chocolates. Thank you so much.